Our today's topic of the discussion is on acute osteomyelitis mainly. So we'll start with the osteomyelitis, what is mean, and what are the clinical features, how will you diagnose the case of osteomyelitis, and how will you treat it. Go through this video a few times and then you will be competent enough to answer the questions forwarded by either externals, internals, or put in your examination of OSCE, MCQ, and MEQ. Let us start with the osteomyelitis. What does it mean? Let us remember the first time it was coined by Neonatal as early as 1834. The root words osteon and myelo. Osteon means bone, myelo means marrow. Both are combined with itis. Itis means inflammation, to define the clinical state in which the bone is infected with microorganisms. So what is the definition of osteomyelitis? The definition is the osteomyelitis is a medical term for bone infection, and it is usually termed when there is infection by the bacteria. Remember the same wordings, osteon, mulinos, with itis. So inflammatory process of the entire bone, not only the cortex and the marrow, it also involves periosteum. The classifications are based on different parameters. So first, let us classify the original osteomyelitis. It could be suppurative, it could be non-suppurative. Suppurative means pus forming, non-suppurative means non-pus forming. So let us see what are the non-pus forming, because we are going to describe only the pus forming osteomyelitis and details of it. So non-suppurative includes tuberculous osteomyelitis. We know in tuberculosis it is not the pus but the caseous material is formed. There could be syphilitic osteomyelitis and there could be actinomycotic osteomyelitis. Now let us examine the classification of suppurative osteomyelitis. There could be a classification based on pathogenesis or spread. There could be a classification based on duration, and there could be a classification based on anatomic type and host type, which is mainly for the chronic osteomyelitis. Let us see the based on pathogenesis. It is the hematogenous, contiguous spread, or direct spread. So based on spread or pathogenesis, there are three types. Now based on duration, which most often we describe it and most often we tell what are the type of the osteomyelitis. Acute osteomyelitis, it starts from day 1 until 2 weeks. It is said to be acute osteomyelitis. Subacute osteomyelitis, probably from 2 weeks to 6 weeks is the time allotted for the subacute osteomyelitis. What is the cause of it? Remember, it can be subacute from the very beginning in some of the cases. Say for example, if there is partial antibiotic treatment or the host resistance is increased or the virulence of the organism is decreased. So it starts not from the acute, from the subacute one. And there could be chronic osteomyelitis, which is usually considered after 6 weeks. Remember some of the conditions where the chances of osteomyelitis is very much increased in that particular host. The conditions are, one is the diabetes, where the blood supply to the affected part is compromised. Remember, 30 to 40% of the people with diabetes who experience a puncture injury to their foot are likely to develop osteomyelitis. Also, there are some conditions which affect the immune system, and in those conditions the chances of developing osteomyelitis is increased, and they are commonest one is the rheumatoid arthritis, and the second one can be called as sickle cell anemia. Remember, in sickle cell anemia, 1 in every 200 people are likely to develop osteomyelitis in given year. Where is acute osteomyelitis most common? In the whole of the body. It is most common in the femur, and the next one is the tibia. Femur 27% and tibia 22%, and next comes the humerus, which is 12%. How does it spread? We have seen the classification based on the spread as well. So one is the hematogenous. How it starts? The initial bacteremia occurs from a simple infective lesion, could be a skin, could be a tooth, or could be a simple infection anywhere in the body. And once there is a bacteria dislodged from that particular area, it is transported by the blood, and this hematogenous is the most common form of a spread in the children. Contiguous, it is by previous surgery, trauma, wounds, or poor vascularity. The commonest example could be following an injury, which is common in adults, could be from the animal bite, from the surrounding tissue. First there will be infection, and that goes to the bone. So that is called extension from the adjacent soft tissue infection, or else over the pressure points in the diabetic foot, the infection can go to the bone. The direct inoculation is penetrating injury, say for example gunshot injury. The exterior, all the materials go inside to the bone and they can infect the bone. Or open fractures is one example. Or during surgery, the bacteria can be lost or contaminate the wound, and then there will be infection of the bone. Now let us see which part of the long bone is affected most commonly in the case of acute osteomyelitis. It is metaphysis of the long bone in pediatric case, whereas in the adults, it is the spine and the ribs. Now let us see why it is most common in metaphysis. Remember, in metaphysis, in a final few millimeters before terminal arteriole reaches cartilage, it is encased in a tube of enchondral bone, and it makes an abrupt 180-degree turn to enter the larval venule. So the arteriole goes closer to the cartilage and then makes an abrupt U-turn. This is also called hairpin arrangement of the arteriole and venule. Now here, because it is 180-degree turn, the circulation is slowed down, and then bacteria can lodge there and starts proliferating. That is the first focus for the bacterial infection. It is same, you can see it, the arteriole, it is artery going and then turns into arteriole, and then it has to terminate in the venule, making an U-turn, 180-degree turn. This is called hairpin arrangement, and here the circulation is slowed down. Now there are certain conditions we should know. The osteomyelitis in the newborn. Any special thing about it to be known? Remember, in the newborn, metaphyseal vessels are likely to traverse the epiphyseal plate, and so it can easily infect the nearby joint. It is happening in the hip most commonly. Less often it can happen in the shoulder, rarely in the elbow. Let us see the bacteriology. What are the types of the bacteria which are going to infect the bone? Remember the seventh position here, Staphylococcus remains the most common organism in all age groups, including children. But there are certain conditions where other bacteria starts becoming commoner. Say, for example, Salmonella. It is common in sickle cell anemia. Streptococcus pneumoniae. It is common in children less than 24 months of age or 2 years of age. Gram-negative organisms, when the infection is coming from the gastrointestinal or genitourinary infection, the gram-negative organisms can cause the infection of the bone, or else when the host immune system is compromised. There are bacteria which are called virulent streptococcal infections. They usually come from the dental extraction, and the bacteria are common pathogen there. The group B, Streptococcus and E. coli, they are common in neonates. That is also called neonatal osteomyelitis. Pseudomonas are common in two conditions: direct puncture of the wound to the foot. With the direct puncture, when there is an infection in the foot, pseudomonas are common. Say, for example, diabetic foot ulcer. Or it is common in the drug abusers or drug addicts. The Staphylococcus aureus, as said earlier, it remains common in all age groups. Let us see some of the special features in special ages. So, septic arthritis, remember, is common in adults, whereas osteomyelitis is very common in children and less common in the adults. Is when it is less than 30 days, there are absolutely little or hardly any systemic disturbance, no fever. The involvement of the infection can be multicentric, and if joint is involved, it could be multiple joint involvement. And when you do the bone scan, it can be falsely negative. So it is really a difficult situation for the doctors and orthopedic surgeons to diagnose the case. Now, if there is an acute osteomyelitis in infancy, what are the special features there? Remember, the metaphyseal vessels are still traversing through the epiphysis and then can infect the joint. And there will be marked soft tissue component and joint involvement we have seen because the metaphyseal vessels are traversing to the epiphysis. It is below the age of 1.5 years. But when you start the treatment at the proper time, either medical or if needed surgical treatment, the healing is very rapid. The special features of acute osteomyelitis in the age group of 2 to 16 years. Now here, the transphyseal vessels have been closed. So the focus of the infection will remain in metaphysis, and from the metaphysis, it starts and remain there and go outside to the surface of the bone. And the findings are typical of the acute osteomyelitis. We will be concentrating on all those features: the periosteal elevation and new bone formation, sequestrum formation, the multiple osteolytic areas, shortening of the bone, and lengthening sometimes can happen due to hyperemia and stimulation of the growth plate. Remember, acute osteomyelitis in adulthood occurs not in the long bones most of the time. It is the vertebrae which are affected. You can see some of the new bone formation anteriorly. How did it progress once the infection starts? And let's see the stages of it, or steps of the progression. First is the inflammatory stage, or the stage of inflammation. Initial lodging of the bacteria while there is a vascular congestion or the abrupt U-turn of the arteriole, here they start the inflammation. And with the inflammation, there is increased intraosseous pressure. Now, increased intraosseous pressure are going to occlude the vessels. Also, the inflammation will also do the intravascular thrombosis. And this in turn will cause the bone necrosis. The stage of suppuration. Now, in the 2 to 3 days after the inflammatory process has started, the pus will be formed. But the pus is under tremendous pressure because bone cannot yield. The bone cannot accommodate the increasing volume of the pus. So pus finds its way through the Haversian system and forms a subperiosteal abscess in 2 to 3 days. Stage of sequestrum is the third stage. The increased pressure we have seen, because bone cannot accommodate, cannot inflate itself, then pressure is tremendously increased inside the bone. And this pressure occludes some of the vessels. Then infective thrombus is occluding the vessels. And so there is a vascular obstruction. And if there is a vascular obstruction to the supply of the bone, then obviously there will be bone necrosis. And this bone necrosis, or part of the bone, when it is necrosed, it is called sequestrum. So sequestrum will be formed. It takes around 7 days. Once the sequestrum is formed and the pus is on this going through the Haversian system and presenting itself over the surface of the bone, thereby elevating the periosteum from the bone, what happens? Then start the fourth stage, that is stage of involucrum formation. Once the periosteum is elevated, it reacts by forming new bone. Not only here, because of the pus, in any condition, if periosteum is elevated, they form the new bone. Say, for example, in case of tumor, say osteosarcoma or Ewing sarcoma, periosteum is elevated and then start forming new bone. That is what we see as the sun ray appearance, or in Ewing sarcoma, it becomes onion peel appearance, layer over layer, the bone is formed. Now, once there is an involucrum, pus is still inside it. It has to find a way to release from the confines of the bone. Pus finds its way to come out by making a hole in the involucrum and presents itself as a subcutaneous abscess. These holes are called cloaca. And from here onwards, there are two ways this can behave. If there is treatment with antibiotic and if needed surgical intervention, there is a resolution of the osteomyelitis. Otherwise, if there is no intervention at the proper time or the antibiotics is not properly given, it turns out to be a case of chronic osteomyelitis. So you can see it, this is whole of the shaft of the femur is dead and new bone has been formed all around. So this has become a new shaft of the bone and this will be dead. The dead bone here is called sequestrum. See, it is surrounded by pus, so all around there is pus and new bone has been formed. This is called involucrum. And ultimately there will be holes in it and the pus will go through it. These holes, once made, these holes will be called cloaca. Same situation, the shaft is completely sequestrated or sequestrum, it has turned into a sequestrum, and new bone has been formed, which is involucrum. So this is the position in plantation of the pathogen in medullary tissue. Vascular and cellular response turns out to be a suppurative edema. Then increased intramedullary pressure occurs, which compresses capillaries and sinusoids, and then infarction of the marrow tissue and cortex occurs. And this is how you can see it, the initial site of the infection. Then it goes through the Haversian system to present itself over the surface of the bone. So it is presented as a subperiosteal abscess. And once the periosteum is elevated, it starts forming new bone. So this is subperiosteal abscess, this is involucrum, and there is a hole in the involucrum which is called cloaca, and the pus escapes through it to present it subcutaneously. And initial infection of the bone, this part is now dead. This dead part of the bone is called sequestrum. How the bone is destroyed? It is destroyed by cytokines or enzymes which are released. There is increased pressure which causes occlusion of the vessels and capillaries are including, and inflammation also causes thrombosis of the vessels or causing the necrosis of the bone. What could be the symptoms? There is a systemic or there is local. So we have to look for the systemic symptoms. High fever, as we have seen in infants, there may be no fever, but they will be irritable, fatigue, and there will be nausea. Generally not toxic appearing, but can be sometimes, and there will be usually dehydration. What will the local symptoms? The attitude of the limb will be in the position of ease. Say for example, around the knee, if there is an osteomyelitis, knee will be kept in 20 to 30 degree of flexion. If there is a hip, around the hip somewhere, it is a fiber position. Fiber means flexion, AB abduction, ER external rotation. This is called fiber position. It is the position of ease to accommodate more of the pus inside the joint. There will be redness, local warmth over the metaphyseal area. The swelling will be around the affected bone in the metaphyseal area, and patient will either refuse to bear weight or he or she may limp on walking. Remember, there are certain conditions when there is acute osteomyelitis in the metaphysis, not infecting the joint, but still the joint will be having effusion. The infection is localized to the metaphysis and still there is a joint effusion. This condition is called sympathetic joint effusion. Now on examination, when you go for the palpation, there will be temperature raised or local warmth. There will be tenderness over the metaphysis. The swelling, in late cases, when it's presented subcutaneous, there will be fluctuant swelling. Otherwise, it will be a diffuse swelling. The joint movement will be decreased or painfully restricted, and there may be sympathetic joint effusion. What are the differential diagnoses? One is rheumatic fever. In rheumatic fever, onset is more gradual than the acute osteomyelitis. Constitutional symptoms are less acute, and more often the problem is confined to the joint. There will be polyarticular involvement, and we know the response to salicylates are dramatic, and antibiotics obviously have no effect on rheumatic fever. Another could be Ewing's sarcoma. Similarities are fever in both, leukocytosis in both, subperiosteal reaction in both, in the form of onion peel appearance in the case of Ewing sarcoma, but there are some dissimilarities. Ewing sarcoma is confined to the diaphysis. It does not affect the metaphysis most of the time, and it responds to radiotherapy, and you do the biopsy, it shows tumor cells, whereas acute osteomyelitis will not show tumor cells. You have to differentiate it from the acute septic arthritis. So in acute septic arthritis, fluid accumulation in the joint occurs earlier, not like sympathetic when it comes late. Pain and inflammation will be limited to the joint. Hardly it goes to the metaphyseal area. Joint movement is grossly restricted, and aspiration of the joint will reveal purulent joint fluids. Let us see the laboratory findings. When we do the blood investigation, there will be increased white blood cell count. The ESR will be elevated in 90% of the cases, but only problem with the ESR is it rises rapidly, peaks in 3 to 5 days, but declines too slowly. So it is not a good guide for the treatment. Increased C-reactive protein, it is a good guide because with the treatment and with the subsidence of the inflammation, it comes with the subsidence of inflammation. Blood culture is positive only in 50% of the cases in children. The most diagnostic and best diagnostic tool is aspiration and culture of the aspirate. If you can find the pus either from the bone or from the subcutaneous abscess presented late, this is the best one. Or bone cultures when you do the bone biopsy or debridement. Let us understand why staphylococcus is the most common. It has got certain good components in itself to infect the bone. First, it is an element of normal skin flora. It has increased affinity for the host proteins, especially the traumatized part of the tissue, bone here. It has got enzymes, coagulase, surface factor A, which neutralizes the host's immune response. And this Staphylococcus aureus can remain dormant for years in its L form. It makes a biofilm, which is polysaccharide slime layer, and this biofilm can adhere to any substance, and this is resisting the reach of the antibiotics or the human defense mechanism present in the blood as well. Remember some of the changes and the duration. The bone changes usually does not appear on the X-ray before 10 days. It takes 10 days after the infection. That will be the first sign of the radiological evidence of acute osteomyelitis. But by the 3 to 4 weeks, 90% of the radiographs become positive. And when you see it, the sign is newly formed bone parallel to the shaft is detected in the case of acute osteomyelitis. So remember, new periosteal bone formation takes 10 days. Osteolysis takes 10 to 14 days. So there will be mottled area of or different areas of the osteolysis of the bone whereby the pus is there, and after 2 weeks there could be metaphyseal rarefaction. Rarefaction means reduction in the bone density. If the plain X-ray is negative in first 10 days, why do we take it? We take it to rule out certain causes of the bone pain such as stress fracture. And in later period of the acute osteomyelitis, all the classical signs will be present in the radiograph: lytic lesions, sequestrum, involucrum, and periosteal elevation all will be present. Remember, osteomyelitis must extend at least 1 centimeter and comprise 30 to 50% of the bone mineral content to produce noticeable change in plain radiograph. So it is in late cases where the bone has been already destroyed, then only it becomes positive. CT scan can show positive results earlier, but we have to consider the cost and the time taken for this CT scan. Is it valuable or not? MRI is helpful in unclear situations and especially in the adults where the vertebrae are affected. Plain X-ray may not show all the findings that we want it to be diagnosed like acute osteomyelitis. The 3-phase bone scintigraphy, it is done especially for the multiple lesions. Ultrasound is used for the aspiration of the pus, where it can give a good guide to put the needle at the exact site. Now let us come to the treatment. Treatment, let us divide in 2 parts. One is for the systemic symptoms, another is protection of the limb. So systemic symptoms, it is fever, pain and dehydration. Fever, antipyretics to be given. For the pain, analgesics are to be given, and for dehydration, IV drip is to be given. You have to protect the limb by immobilizing it. Immobilization by slab or splint in certain situations is obviously very good. And you must not allow the patient to walk because the bone is weak, so it can easily be fractured. Remember some of the principles. Antibiotic is effective before the pus is formed. Antibiotic cannot sterilize avascular tissue. So sequestrum which become avascular, it is a good nidus for the bacteria to remain there because the antibiotic cannot sterilize it. Antibiotic prevents formation of the pus once it has been removed, and pus removal restores the periosteum and also its blood flow, so the metabolic activity of that part of the cortex is restored. Antibiotics should be continued after the surgery has been performed. So about the treatment, remember in acute osteomyelitis, most of the time medical treatment is quite successful. For that, one must give antibiotics before obtaining blood and bone aspirates. Do the bone aspirate first, because once you give the antibiotics, the aspirate will not show positive culture. Remember, sometimes one or more antimicrobial agents may be useful to be given to the patient. And what is the mode of giving antibiotics? It is intravenous route. Cannot be intramuscular or cannot be oral. It must be given for 3 to 6 weeks until C-reactive protein becomes normal. Many say it should be continued 4 to 6 weeks. And many of the authors, they have in their statistics, they have come to the conclusion that give antibiotics intravenously for 2 weeks and can substitute it with the oral therapy. So there are different schools of thoughts. The antibiotics, how will you choose? For the methicillin sensitive Staphylococcus aureus, it is clindamycin, works very well. The vancomycin and linezolid are specialized for the methicillin resistant Staphylococcus aureus. Remember, linezolid has got some special activity. It is active against methicillin-resistant staphylococci and vancomycin-resistant enterococcus as well. So if you find that the organism is the enterococcus which has become resistant to the vancomycin, better to start linezolid. And duration treatment 4 to 6 weeks. And many of the times you have to do the surgical intervention. With the surgical intervention, you have to drill the bone. Whether drill or not, always try to drill it. Always drill. You drill it, if pus comes out, you take it for the culture and sensitivity test and also gram stain. Remember some of the indications for the surgery given by Nade's. Abscess formation is one of the indications for resorting to the surgery. In case of severely ill and moribund child with features of acute osteomyelitis, you have to do surgery. And if you have started the medical treatment with antibiotics, IV, and there is no response in 48 hours, you have to resort to this surgery. What are the complications? The acute osteomyelitis can turn out to be chronic osteomyelitis if not properly treated. If patient puts weight or the limb is not protected, there will be pathological fracture, extension into the joint of the infective organism can produce septic arthritis. And sometimes, because in a metaphyseal area, if the epiphysis is involved or destroyed, there will be shortening of that limb. Or part of the epiphysis is destroyed, then one side will keep on growing and another side where it is destroyed won't grow, so the limb will be deformed. So we come to our end of the subject. Go through 2 times and you will be competent to understand the concept of the acute osteomyelitis. Thank you very much.